Sir, good evening, ji. Garg Sahab.
Good evening, everyone.
Good evening. Good evening.
Dr. Nirmal, good evening, sir.
Good evening, everyone. We are live and we are live on the YouTube as well as special Facebook channel. And people are joining. Welcome to the...
Dr. Bansal. It seems
Yes,
to be...
sir.
Yeah.
श्रीपाद और राहुल अभी ज्वाइन नहीं किया ना?
I'm here, sir.
Rahul is here. Rahul is here.
Yes, I'm here, sir.
Yeah.
Everybody has joined, so
Yeah, Shripad
we
is
will...
also joining. Yeah. Manish, hello.
Isham, we should not discuss anything because then it is live now. So
Yeah, sure.
we shall be starting in 2 minutes. I take the opportunity to welcome Dr. Shyam Sundar, President, Association of Physicians of India, who has been at the helm of coordinating and having this Freedom Series goes on. For those who were first time here, let me tell you that Freedom Series is a joint effort between Association of Physicians of India by the IAN, and the name came because the first session started on 26th of January 2022. Today is the session 5. We already had 4 sessions in the past, which has included on stroke, epilepsy, Parkinson disease, etc. And today we have on infection disease. Then, as you all know, that physicians are the one who are the first line offering the treatment in different parts of the country where neurologists are not there. And this become very important that the physician being made aware about the latest happening in the field of CNS infection. Today we have galaxy of people. Along with me is President-elect Dr. Gagandeep Singh, who is from Ludhiana, and his colleague and Dr. Bansal, who has been well known in API circle. He's also been there. And Dr. P.K. Maheshwari, the neurologist from Agra, who has been very, very active, and predominantly he and Dr. Gagan are the one who coordinated to see that this sessions goes regularly and jointly to benefit the physician at large. The speakers are excellent and they have been expert in the CNS infection with a lot of credential. The opening batsman will be Dr. Sripat Pujari, and if you look at the last 2 years COVID time, annals of Indian Academy of Neurology, you will find that every alternate journal had an article from Sripat Pujari on various diseases involving the brain, predominantly CNS infection. Dr. Ravindra Garg needs no introduction. He is probably the champion in CNS infection with a large number of paper expertise in tuberculosis, SSPE, slow viral disorder, and many other disorders, many papers, and highest number of citation for his article on tuberculosis. And then we have another silent expert, Dr. Dhanpat Kochar from Bikaner. Dr. Kochar has been done the remarkable work in cerebral malaria from a very small city and put the Bikaner on the map of cerebral malaria in the world. And then lastly, don't forget Dr. U.K. Mishra, another champion in CNS infection with a lot of work done in various infections, is going to speak to you about the neurotuberculosis. The chairperson for today are Dr. Meshram. Dr. Meshram is international person with tropical neurology section of World Federation Neurology chair, and he has been chief coordinator for various public forum activities in India and has been very, very active. He, along with Manish Modi, who is the convener of tropical neurology subsection, would be part of the chairperson, and the moderator of today is Dr. Rahul Kulkarni, another gentleman who is organizing a tropical neurology big meeting next weekend with 450 plus delegates joining, with all the infections being talked about. So we have galaxy of people, and with that note, I think we begin the session today, and I would request at the outset to have few words from Dr. Shyam Sundar, the president of API.
Thank you, Dr. Surya, and thank you for inviting me. Actually, this is very nice that we are having joint lecture series, API and IN. As far as infections are concerned, you very rightly told that physicians are the first line of doctors who come across these infections. And I think once we have lectures of their expertise, lectures from the experts of the CNS infection, will be greatly benefited. And I mean, these infections could be, we come across bacterial infections like tuberculosis, tubercular meningitis, septic meningitis, encephalitis, slow viral diseases, COVID infection, fungal infections like cryptococcal meningitis, neurocysticercosis, malaria, and the list goes on. So I'm sure we'll all be benefited by this lecture series. And I once again thank Dr. Surya and and our coordinator, PK Maheshwari, very energetic. And he, in last 10 minutes, called me 3 times. So he's really very, very enthusiastic. So with these few words, I request you to go ahead with the program.
I wanted to give you a good news, Dr. Shyam Sundar, that first time ever you will have a session by API in the upcoming AOC and IONCON 2022 in November in New Delhi. And I have kept a session, and I sincerely hope that next APCON, you will have a session jointly with Indian Academy of Neurology to reciprocate it, a long-term relationship between the two organizations, which of course are all of us as born from API. We were first physician, then we have become the neurologist. So that's something which I would request you that you should endorse. Dr. Maheshwari, of course, is going to follow that up. Thank you so much. And with that note, I hand over to Dr. PK Maheshwari and Dr. Rajendra Bansal to take the session forward. Thank you.
Thank you, sir. With so many learned speakers and the moderators, chairpersons, now I should not waste anything. And then I hand over to Dr. Meshram and Dr. Manish Modi over to organizing the remaining part. Over to Dr. Meshram and Dr. Modi.
Thank you, Dr. Maheshwari. And I welcome you all for this session. It is going to be very interesting and so very well thought of session, and the speakers are expert in their field. All these are day-to-day common problems faced by physicians. Some of these may be rarer, like SSPE and slow virus infection, but COVID, tuberculosis, and cerebral malaria are day-to-day problems. So we'll straight away go to the session, and the first talk will be by Dr. Shripad Pujari, who is a consultant neurologist at Dinanath Mangeshkar Hospital and Noble Hospital, Pune. His areas of interest are multiple sclerosis, neuromuscular NMO spectrum disorders, and neuroinfections, and neurology of COVID. And he has published a lot of papers, and he keeps publishing very regularly. He's a prolific writer and a researcher, and he's past secretary of Neuro Society of Pune, and he's currently the treasurer of Maharashtra Association of Neurology. And he regularly conducts teaching modules for residents through various teaching platforms. He's actively involved in educating neurology trainings, physicians, and general practitioners. And he's also involved in patient education program and education program. Welcome, Dr. Shripad Pujari, and over to you, Shripad.
Very much, sir, for such a kind and elaborative introduction. I am feeling really honored today to be introduced by Meshram sir, who is the World Congress of Neurology representative from India, and he has been a guide and a mentor during the journey that I have traveled, both with demyelinating diseases as well as infections and during COVID. And it is a real privilege to have to speak on a forum, which is a joint one between IN and API. As Dr. Surya rightly mentioned, we have emerged, we're born out of being physicians, and to be able to share our experience with my colleague neurologists and my physicians. I'm going to highlight few important cardinal publications that have come up from India, along with references from international scenarios. And without wasting much time, I'll start my lecture. So as I said, the journey of learning about COVID went on as we went on working for COVID patients. And I have to say with humility, we are still learning. Like if you remember, with the arrival of mycosis, and then with the arrival of issues related to vaccinations. And I'm going to just briefly try and cover as much as I can with the references. So as we all know, there are several similarities, but differences as well between neurological complications between the SARS, MERS, COVID and COVID-19. But COVID-19 has a much higher propensity to affect other systems, and respiratory involvement may be mild. We've learned that by now, but they may develop clinically significant extrapulmonary and in the extrapulmonary neurological manifestations. And all parts of the neuraxis are involved, and manifestations are seen during and even after the acute illness. So the virus directly can damage the tissue as well as the endothelium itself. It causes thromboinflammation, we all know, and it leads to dysregulation of immune responses. And we all know by now there is maladaptation of ACE2 related pathways, which is another mechanism by which it damages the tissue as well as the vessels. In autopsy, we have found neuronal necrosis, glial cell hyperplasia, and on immunohistochemistry, we have seen elevated expression of cytokines and infiltration by mononuclear cells within the tissue itself. So the virus enters by direct invasion of neural parenchyma, we all know, by nasal mucosa, lamina propria, cribrosa, and olfactory bulb. And then there can be retrograde axonal transport as well. Virus can be directly tropic to the nervous system, or it can produce para-infectious or post-infectious immune-mediated disease. But much commoner are neurological complications of the systemic effects, such as metabolic encephalopathies, secondary bacterial sepsis, hyperthermia related, drug-induced, and because of prolonged ventilation, we all know CINM. Now, neurological manifestations, as we've lived through them, occur in the acute phase as well as in the late phase. In the acute phase, the direct manifestations, we all know, are some of them are mild or what we call the constitutional ones. But in addition to myalgia, we can also have a direct myositis, and we can see encephalopathy or encephalitis. And we all know strokes are probably first or second commonest manifestations, maybe after encephalopathy. And then hemorrhages are also uncommonly seen. And as indirect manifestations, fever itself can cause its problems. Hypoxia, we know, is a very common issue because of respiratory involvement, and infection causing systemic encephalopathies and encephalopathy due to secondary bacterial sepsis. And in the late phases, again, we can see some of the similar constitutional symptoms and anosmia which carry on, or then later on we can see post-infectious manifestations such as edema and Guillain-Barré syndrome. And strokes do not stop even after the fever is over. They continue up to 2 to 3 months. And then the last very important point, which as yet maybe we as neurologists and physicians have not yet notified with any system at all, like we saw after the 1918 Spanish flu, when many patients were left with encephalitis lethargica, and the incidence of Parkinson's exponentially rose a few months to years after that pandemic. Whether we are going to see that again, we don't know. We should go on following up our patients and trying to compile the delayed neuropsychiatric manifestations. And we all know by now the neuropsychiatric symptoms in the form of psychosis, cognitive affection, and affective disorders. And delayed, we are seeing CNS vasculitis. Let us have a look at briefly at descriptions of individual manifestations. So in addition to hundreds of international publications, like Surya sir said, we in India have managed to notify and publish our own experiences. There have been from North, West, East, and South India. There have been publications which address all three waves. There are some in relation to just one wave, and there are single center as well as multi-center studies. Let us see what these studies tell us. We all know we used anosmia and to a lesser extent agusia, there is loss of taste, as a herald for appearance of COVID along with fever. And it was seen in a good up to 85%, and that heralded a less severe overall infection and occurred in isolation, suggesting that there is direct involvement. You can see here in the coronal section, direct involvement of the olfactory nerve, and the inferior frontal gyrus rectus MRI here showing direct involvement of the olfactory cortex as well. And usually it recovers within 4 weeks. And other cranial nerves, such as, I'm sure many of you see, abducens and trigeminal nerve involvement was also documented. Headache has been very common. Any viral infection will produce that. But later on, a tension type quality of headache was also seen, and it could be due to direct invasion of SARS-CoV-2 virus in the trigeminal endings. It could be because of trigeminal vascular activation, like it is seen with migraine or cluster headache, release of pro-inflammatory cytokines, and fever, hypoxia causing secondary headache. We know any systemic involvement can cause a secondary headache. And a new type of headache, personal protection equipment related headache, when a healthcare worker stays for hours together with this PPE, sweating and other dehydration, and not eaten for hours together may itself produce headache. Dizziness was reported in majority in the acute phase, but settles as the acute illness recovers. Mild fatigue, we all know, is a very common symptom of many viral infections, common in acute as well as convalescent phase, and may continue for months, and significant cause of disability and loss of function. Seizures were seen uncommonly, although encephalopathy and stroke, and then viral and post-viral neuropathies were the commonest, but seizures were also seen. And that could be just because of fever-triggered activation of neuroinflammatory pathways facilitating epileptogenesis, direct invasion of virus, and we call it direct viral encephalitis, where I have a slide on that. And then metabolic electrolyte disturbances, hypoxia, and other inflammatory and infectious processes. And in some patients, we saw sporadic sharp waves, that is epileptiform activity, but the commonest finding when people were post-ictal was a generalized background slowing. Encephalopathy was the first or second commonest manifestation, delirium, coma, confusion, in patients in whom brain inflammation has not been proven. And again, as I say, wide range of causes, metabolic, drugs, and maybe certain toxins such as cytokines were involved. So endothelial dysfunction, hemodynamic instability, and immune activation with release of cytokines were the proposed pathophysiological mechanisms. Coming to this important slide, encephalitis. Some actually in the initial period of pandemic were reported on, proved on biopsies, and the clinical evidence of brain inflammation is accepted of having CSF pleocytosis and brain imaging changes and focal abnormalities on EEG. Neurological features mostly started up to 17 days after the onset of fever and respiratory symptoms, and few patients had only fever with no respiratory features. And the symptoms were standard that would be seen in other encephalitis, and there were increased lymphocytes, virus detection, that was not very common, and focal EEG abnormalities, and the damage was caused by direct tropism and host inflammatory responses. If you see in this couple of MRIs, there was basal ganglia, thalamic involvement, as well as mesial, that is a medial temporal. Here you can see the thalamic involvement very nicely. Ischemic stroke, by far first or second commonest manifestation. Here we have had large series from India, both North as well as South India. And initial studies as well had a variable incidence reported, and the association could be causative, triggered, or incidental. And I'm going to show how. Majority of patients were older than 60 years and with known risk factors such as hypertension, diabetes, and hyperlipidemia, where we thought that it was triggered by destabilization of the carotid plaque. As you all know, majority have large vessel disease, but younger stroke patients have also been reported who had no classic risk factors, where we thought it was more causative. And cerebrovascular symptoms began at a median of 10 days after the onset, but rarely the strokes preceded, and few had only cerebral vascular symptoms. And we know we were doing COVID testings during that time, during those times of pandemic, and many of them were found to be COVID positive. Large or medium vessel ischemic strokes, D-dimer and CRP was raised, consistent with pro-inflammatory and coagulopathy. Some had positive LA, cardiolipin, and anti-beta-2 glycoprotein antibodies. Strokes were more severe, increased complications, more disabling, and had a higher mortality. And immediate anticoagulation with heparin was recommended, as you all know and remember. And this approach might also reduce COVID or ischemic stroke. Several randomized trials are looking at role of anticoagulation, including newer anticoagulants. Here you see we had anterior circulation, that is the ICA, MC, a large infarct, small infarcts, as well as the posterior, that is the vertebrobasilar circulation, large as well as small infarcts seen. And cerebrovenous sinus thrombosis, we managed to compile a larger series and had our own, expressed our own opinion about CVST. It was much less common, as I said, and symptoms occurred in symptomatic as well as asymptomatic SARS-CoV-2 infection subtypes. It occurred up to 2 months after COVID infection, and in patients who did not have any traditional risk factors. Males were equally susceptible, and like the traditional VST, which is a female dominant disease, and more severe in patients with severe pneumonia. And there probably was a combination of low-grade DIC, transient antiphospholipid antibodies, as I earlier said, intimate and cytokine storm. And so again, the mechanism, we say coagulopathy, activation of thrombotic pathological infection, monocyte activation, inflammatory processes, realization of the plaques, and vasculitis, and uncommonly cardiac as well, triggering atrial fibrillation and causing endocardial damage. ICH was also seen, but much rarer because of coagulopathies as well as SARS-related ACE2 downregulation, which leads to vasoconstriction, blood pressure spikes, and arterial wall rupture. We all know edema and myelitis were seen. Edema, as we all know, is a syndrome of multifocal demyelination occurring weeks after the infection with focal neurological symptoms and encephalopathy. And the common manifestations are speech, language, seizures, and encephalopathy up to median 9 days after the onset of headache and myalgia. And MRI was typical, as you see, white matter lesions, and improved after IV immunoglobulin or steroids. Myelitis was also reported rarely. And in peripheral demyelination post-viral, we've had one of the largest papers from Western India, and the salient features were that the incidence was not particularly higher than what might be expected. Neurological symptoms started around 7 days after respiratory or systemic features, and the classic GBS was the commonest. Miller-Fisher was also seen. Respiratory failure was seen, as it would be in the standard GBS. And along with that, myositis was rarely reported with raised, we all know, raised CPK levels as a marker of muscle injury. Invasion of the muscles by the virus entering the cells via ACE2 receptors or cytokine storm in the advanced phase were the proposed mechanisms. And we all know, we have seen uncommonly critical illness, neuromyopathy, which has also been reported. Proposed risk factors are severe respiratory distress, cirrhosis, and sepsis. And we know by now the COVID fog, which includes some of them having just psychiatric manifestations such as psychosis, and then subtle or some having significant, functionally significant cognitive decline, which includes memory loss, poor concentration, lack of interest, impaired syntax formation, judgment, and executive functions. Affective syndrome has also been seen, which includes mood disturbances, lack of energy, changes in eating and sleeping, and emotional ability. And now, the more delayed, more seen in the second wave, the most devastating, dangerous secondary complication, infectious complication. We've been through it ourselves. We all have managed as a multidisciplinary team. There was an alarming rise in this invasive mycosis, which included mucor, aspergillus, and dual infection, simultaneous mycosis and COVID infection, as well as sequential seen up to months after recovery from COVID. Presentation of the mycosis was similar to non-COVID mycosis, which included paranasal sinuses, orbital, cavernous sinus, base of the skull, mass lesions, and strokes. We thought there were two major risk factors: diabetes and use of steroids, and new onset diabetes. We all know seen after COVID increased chance of ROCM several times. So there were four factors responsible for this mycosis: COVID related, immune disorder, high ferritin, hyperglycemia, therapies such as steroids and immunosuppression, past illnesses, and host factors. Maybe some of them were more susceptible and their immunity was compromised. And now the vaccine related, it's impossible for me to go into details of this, but I'm going to highlight salient features. The commonest are the constitutional type symptoms: headache, fatigue, and myalgia. But the most devastating was, we all know, WIT, the post-vaccination complication of cerebral venous sinus thrombosis. Bell's palsy was one of the frequent ones, although by and large they are rare, maybe 1 in 50,000 to 1 in lakh, but by far Bell's palsy was seen as the commonest. And then we all know acute transverse myelitis and acute disseminated encephalomyelitis was reported rarely, and GBS has also been seen after most of the vaccines. There has been reactivation of herpes zoster rarely. But with this massive COVID vaccination program, the number of serious neurological events is very small, and we need large collaborative prospective studies to prove or disprove causal association between these complications and vaccines. So as I said at the beginning of my lecture, unlike the previous SARS, where we had very rarely, very uncommonly anosmia or myopathies, and rarely ischemic strokes, encephalopathy, or neuropathy, with the MERS, again, rarely some ischemic strokes, encephalopathies, and extreme rare intracerebral hemorrhage. And like that, with this new SARS-CoV-2, most of the extrapulmonary, and in that, the neurological manifestations have been much more frequent. They were seen even with minor or asymptomatic respiratory COVID, and they included all portions of neuraxis, not just during COVID, but even after COVID and in asymptomatic COVID. And it went on to cause immune dysregulation of the kind where we saw an alarming rise of fungal infections. And then the vaccine itself has given us a little bit of goosebump by itself. And then there have been impact on neurologic services in the form of society avoiding OPDs, obviously, and drug compliance was compromised, leading to breakthrough seizures, stroke recurrences, and video consultations given to diseases where ideally physician assessment is cardinal, but we had to have a compromise, and planned admissions were avoided, immunotherapies were postponed, like we are giving rituximab and IVIGs, they were postponed, and no beds were available for neurology patients during the peak of the pandemic. So to summarize, SARS-CoV-2 causes systemic complications, multiple system involvement, neurological manifestations are different, more extensive than the previous coronaviruses. They can be seen during acute and also post-COVID complications, rarely may precede respiratory symptoms, especially the strokes. Some patients may never had respiratory symptoms. Some complications like stroke at MGBS may occur weeks to months after COVID. And I have reiterated mechanisms several times. We have to remember, and it's very important, it may sound theoretical, but this will kindle our work on how to generate medicines, therapies to prevent some of them, and more basic science research is needed to confirm all about. Therapeutic trials are needed to devise towards preventing complications and treatments such as anticoagulants and antivirals. And some manifestations are just like due to metabolic impairment. The proportion of patients with neurological manifestations is still not that large. However, say if this proportion of world population is expected to get infected, then the overall number of patients with neurological diseases is going to be very large. I hope I tried to crystallize on what all was seen within the nervous system, and I hope I have tried to make concepts clear. Thank you for giving me this opportunity again, and I end my sharing of views here. Thank you.
Thank you, Dr. Shripad, for that excellent review of post-COVID neurological complications. There will be a lot of questions, but we'll take the questions in the end. And now I request my co-chair, Dr. Manish Modi, to introduce the next speaker. Manish.
Thank you, sir. I think the next speaker needs no introduction. Most of us know Dr. Ravinder Kar and his expertise in the field of CNS infections. Presently, Dr. Garg is heading the Department of Neurology at KGMU Lucknow, and he has numerous publications, a number of publications of CNS tuberculosis, NCC, SSP, and almost every CNS infection. It will be a pleasure to listen to him on a bit atypical subject. Most of us have been listening to him on CNS tuberculosis most of the time, but SSP is an interesting and a challenging neurological disorder, and I'm sure we'll learn a lot from his experience during this talk. Over to Dr. Ravinder, please.
My screen visible?
Yes, sir. Yes, sir. Is it visible?
So, thank you, Dr. Nirmal and Dr. Shyam Sundar for giving this opportunity to present in front of physicians and unusual audience for us. And what I am choosing, which I think is now important, physicians should also know about these infections. And I will start my presentation with this report. This is an actual case which we saw and we diagnosed. This was a young woman presented 4 weeks after normal vaginal delivery with bilateral vision loss. This lady we saw in obstetric department, and she was taken transfer after this delivery. And this vision loss was first noticed in the 20th week of pregnancy. After delivery, this vision loss did not improve. In postpartum period, she started having some abnormal movements. At that point of time, she was taken transferred to our ward, and in our ward, neurological examination, she was fully conscious and oriented. and her blood pressure was throughout normal. But his vision loss was limited to finger counting. This was a cortical type of vision loss because pupil response was normal. Other neurological examination was also normal. An MRI was performed, which showed hyperintensities in post-occipital lesion. And you know, this kind of hyperintensity is very specific for posterior leukoencephalopathy syndrome. And at that point of time, a diagnosis of postpartum eclampsia was considered, a sort of hypertensive encephalopathy. And meanwhile, this patient had some abnormal movements.
क्या नाम आपका? घर कहाँ पर?
This lady showed periodic jerking, and this periodic jerking involved almost whole of the body, more of a truncal, and we considered the possibility of subacute sclerosing panencephalitis, and CSF examination was done that confirmed the presence of anti-nasal antibodies in the CSF. And this lady, which was initially thought of eclamptic encephalopathy or posterior leukoencephalopathy syndrome, turned out to be a case of SSP, subacute sclerosing panencephalitis. What is an SSP? SSP is I will beg to differ with Dr. Meshram that it is an uncommon infection. We consider it is a very common. If you have such 4 cases at a time in ward, then I will consider it is a common infection. The SSP is a commonly encountered progressive encephalopathy caused by persistent measles infection of the brain. This SSP, the incidence of the SSP is directly proportional to the incidence of measles in the population. And as per WHO estimate, the global incidence of SSP ranges from 4 to 11 SSP patient per 1 lakh measles cases. This SSP, if measles occur early in the childhood, the risk of SSP is much higher. Especially if measles occur less than 2 years of age, then chances of SSP is 4-fold higher than if occurs after that. India is one of the country where the measles is very common, and subsequently SSP is also very common. Who is affected? Who are affected with the SSP? SSP typically affects school-going children, and it manifests clinically at around 12 years of age, though range is quite wide. And from measles infection, first measles infection to development of SSP, that is the median latency period of developing SSP ranges from 2.5 to 34 years, and the median latency is 9.5 years. The males are much more affected than females, but we have published 2 papers. One where compiled the data of patient presenting 3 years or less than 3 years of age, and we also compiled the data where patient presented after 35 years of age, up to 60 years this SSP can present. What are the clinical features of SSP? Usually this SSP present with poor scholastic performance. In school, teacher complained that child has less attention in the studies, and marks is becoming very low subsequent in the exams. The poor scholastic performance is the initial manifestation of SSP. Second, the characteristic manifestation of SSP is periodic myoclonus, progressive difficulty in walking, and in later stages, florid pyramidal signs, akinetic mutism, and ultimately patient develops vegetative state and dies. This is one of the characteristic SSP patient. There is a periodic myoclonus involving whole of the body, axial, appendicular, as well as face. Usually, the SSP evolves in a period of 1 year to 9 years to death. From the start of the illness to death, it ranges from 1 year to 9 years of the age, and 1 year to 3 years, and after that patient dies. But at times, fulminant SSP, which develops within 6 months of the first symptom, these patients often are confused with autoimmune encephalitis. Unless we are aware with this entity SSP, then we are likely to miss these patients and consider them as a autoimmune encephalitis. And these are one of the patient who presented with hyperintensities, gray matter, white matter hyperintensities. And initial diagnosis, our initial diagnosis was this autoimmune encephalitis. And when we tested autoimmune encephalitis, tested the CSF antibodies, autoimmune antibodies, they all were absent. However, in this patient, anti-major antibody titer was detected, and the diagnosis was fulminant subacute sclerosing cholangitis. It's very common. Some patients with the dementia, progressive dementia, can be manifestation. Progressive dementia can be a manifestation of SSP in adult patient. Generally, these adult patients do not have characteristic periodic myoclonus, and the high index of suspicion is required to diagnose SSP in these patients, and especially the older patients. This was the paper which I compiled. All elderly patients who presented with SSP, and many of them they mimicked autoimmune encephalitis. In addition to this characteristic changes, progressive mental decline, periodic myoclonus, the eye changes are in certain number of patients are characteristic. Around 1/3 of the SSP patients have some eye changes, and ophthalmic examination is mandatory in each and every patient. And chorioretinitis with macular involvement is the characteristic manifestation. Necrotizing retinitis is characterized by dilated tortuous veins, retinal hemorrhages, exudate, and pigmentary changes. In addition to this chorioretinitis, some patient may have papillitis and optic atrophy as well. EEG is quite characteristic. There is a periodic electroencephalographic discharges, and this characteristic EEG periodic changes. Each episode of periodic change is similar. This is known as stereotyped periodic changes. Neuroimaging shows periventricular hyperintensities on MRI, T2 and flare MRIs. But many times white matter changes, gray matter changes has also been described along with these white matter changes. And in this particular patient, this imaging changes were restricted to brainstem. This pontine changes, and it looks like a distinctive mosaic-like picture on MRI. the diagnosis is confirmed by doing CSF examination, and in CSF, anti-measle antibody is detected, then diagnosis is considered definite. So there is a diagnostic criteria of SSP that includes clinical, EG, electroencephalographic, and presence of anti-measle antibody titer. Brain biopsy is rarely performed, and if 3 out of these 5 criteria are fulfilled, then diagnosis is certain. What is the pathogenesis of SSP? I made this simplified diagram. They start with the measles virus viremia during initial measles infection. And as I've told, this if measles infection occur before age of 2 years, then in subsequent years, the chances of SSP greatly enhanced. So because of immature blood-brain barrier, this virus enters into the brain. And of course, so many patients are affected with measles, so many children are affected with measles, but only few of them develops SSP. So a host genetic susceptibility is probably is there. So when this measles virus crosses blood-brain barrier and reaches into the brain, once in the brain, because of several regions, this viral genome gets changed. There is a mutations in the viral genome, and that changes, this genomic changes in the virus leads to persistence of measles virus in the brain. And these measles virus do replicate within the brain cells, and they transmit from one neuron to other brain neuron through synapses. Transsynaptic spread of virus leads to diffuse spread of these viral particles throughout the brain. And in response to that, there are inflammatory changes in the brain, and subsequently there is a neuronal loss. And this is the possible hypothesis related to the pathogenesis of SSP. As far as treatment is concerned, there is no definite treatment is available. But many drugs are considered to stabilize the course and retard the progression of the disease. Very infrequently, this improvement in the stability has been noted, that too for a short time. Usually, whenever treatment is started, it is given for long period, probably lifelong. There are so many drugs which has been used, that has been tried in SSP, but I will enumerate only the drug which has been considered now the so-called most effective drugs. Isoprinosine is a drug, oral drug, and it is given in the doses of 100 milligram per kg. And this is a costly drug, is largely not available, and it is difficult to afford because the treatment is lifelong. Intrathecal interferon, this is the treatment which we are following now, and we inject 3 million units weekly or fortnightly of intrathecal interferon alpha. Currently, the most effective treatment which is considered is intraventricular interferon along with oral isoprinosine. But randomized controlled trial, which was started some time back, was found that even this form of treatment is grossly ineffective. So, in nutshell, there is no definite treatment for SSP as of now. As I've told, the death usually occurs within 1 to 3 hours after diagnosis. If it is a patient is having fulminant course, the patient may die within 6 months. less than 50% of the cases survive more than 2 years. So ultimately, what is left? What is left is the prevention. And the only remedy available to us against SSP is measles vaccination. And in the countries where there is a universal measles vaccination took place, the incidence of SSP has been dropped to almost 0. And whenever in developed countries, whenever there is a SSP cases reported, that is because of periodic spurts of measles infection, outbreaks of measles infection that takes place in different communities. Why I am presenting this to our physician colleague? Because in lockdown, this vaccination against measles has badly affected, and this is a global phenomena. This vaccination has been badly affected during lockdown and COVID. So in few years from now, we are likely to see a large number of SSP patients. So be careful, be familiar with the SSP. Many of these patients we have taken transfer from psychiatric ward. And because of this abnormal movement and poor scholastic performance, parents think that the patient you have that is doing something to avoid studies. Now, I have chosen another slow virus disease rather than slow infectious condition, which is not that common, that is exceptionally rare. As far as slow virus is concerned, the only slow virus infection which is more common is this HIV encephalopathy and this progressive multifocal encephalopathy. These are also slow virus infection that I'm not going to deal. Other group of disorder, slow infection, this prion disease. And they are considered slow disease because after an extended period of latency, the clinical manifestations appear. And most of them ultimately leads to death. Creutzfeldt-Jakob disease is a condition which should always be considered in patients presenting with rapidly progressive dementia. There are 3 types of Creutzfeldt-Jakob disease. The most common one is the sporadic one, and in 85% of instances, it is the sporadic variety of the Creutzfeldt-Jakob disease which is we encounter. Iatrogenic CJD has been reported following many iatrogenic CJD was reported following corneal transplant. And this third type is variant type of Creutzfeldt-Jakob disease, and this is a infection which is acquired from eating contaminated meat, and also from the is also known as mad cow disease. This pathogenesis of this prion disease, this prion proteins are normal part of our cells, and with the various regions, these prion protein get molded, and this molded protein further molds other normal prion proteins, and this chain continues. This molded prion protein is toxic to the cells and brain cells, and this leads to what we call as Creutzfeldt-Jakob disease. These all prion disease pathologically manifest with spongiform encephalopathies. They are formation of multiple vacuoles, giving appearance of a sponge. Mode of transmission of prion disease, Creutzfeldt-Jakob disease, is largely not known, but studies have shown that in some of the prion diseases, a variety of body fluids are infectious: spinal fluid, blood, saliva, urine, and feces. This prion disease are clinically characterized by three manifestations: dementia, myoclonus. In Creutzfeldt-Jakob disease, myoclonus is frequently subtle. In SSPE, myoclonus is more violent, but in Creutzfeldt-Jakob disease, myoclonus is usually subtle and it is fragmentary, involved one portion of the body, is not generalized. And one of the characteristic manifestation of Creutzfeldt-Jakob disease is periodic sharp wave discharges. And this is almost pathognomonic of Creutzfeldt-Jakob disease. Neuroimaging is very suggestive and is characterized by gray matter hyperintensity. Gray matter hyperintensity, and this manifests as cortical ribbon and hyperintensity of the basal ganglion. And this characteristic feature distinguishes Creutzfeldt-Jakob disease from other types of slow virus, where this progressive dementias. This invariant Creutzfeldt-Jakob disease, the hyperintensity is localized to pulvinar of the thalamus. Usually, diagnosis is clinical, but confirmatory diagnosis requires this test, which I have recently, this has been reported, real-time quacking-induced conversion assays. I'm not familiar with this test, but this has been quoted as one of the most specific tests if performed in CSF for the diagnosis of Creutzfeldt-Jakob disease. Usually, diagnosis is based upon a criteria, clinical criteria and supportive criteria. Clinical criteria include myoclonus, visual or cerebral disturbances. Visual, characteristically, the patient is having cortical blindness, pyramidal and extrapyramidal signs, and ultimately kinetic mutation. EEG shows periodic discharges, elevated CSF 14-3-3 protein, and characteristic imaging changes, which I have just described. There is no treatment, and usually patients succumb to illness within 6 months to 1 year. For diagnosis of this Creutzfeldt-Jakob disease, again, a high index of suspicion is required, and to differentiate it from late onset SSP becomes crucial. And in that case, a CSF should always involve anti-visual antibody titer. Thank you very much. Thank you. Thank you, Dr. Mishram. I've finished.
Right. Thank you, sir. I think Dr. Mishram, sir, should we take some questions or we should take it later?
So we'll take the questions in the end.
Right, sir. Fine.
Yeah.
So I think we will you introduce the next speaker for the next?
Yeah.
Yeah.
Yeah. Professor Mishra is our next speaker. Can I have the slide?
Won't it be Dr. Dhanpat Kocher, sir?
No, first we'll be doing Dr. Kocher, and Dr. UK Mishra will be doing at the end.
Yeah.
Okay, fine. So we'll go Dr. Dhanpat Kocher, CV for Dr. Dhanpat Kocher. Yeah, Dr. Dhanpat Kochar. Can I have the CV for Dr. Kochar? Dr. Kochar is a former senior professor and head of the Department of Medicine at SP Medical College, Bikaner, India. And he's in charge of Cerebral Malaria Research Lab and is chairman, Research Advisory Committee, Multidisciplinary Research Unit, SP Medical College, Bikaner, Rajasthan, India. And he's an expert on cerebral malaria. And I would like to, mention one incident about Dr. Dhanpat Kochar, that in one of the international conference, he was asking some question about the malaria. And then the speaker said that you should read the article by Dr. Dhanpat Kochar. And Dr. Dhanpat Kochar said that I am Dr. Dhanpat Kochar. So it's a great pleasure inviting Dr. Dhanpat Kochar to present about cerebral malaria.
Yeah, thank you, Dr. Mishram, for these very nice words. Thank you, Dr. Surya, Dr. Shyam Sundar, and all others who had given me this opportunity. I will be taking the journey by talking on malaria in three different portions. First, we will discuss what we were knowing in last century, then what we had known in about the 20 years of this century, and then third, what is expected from us for complete eradication and what are the things for future research. So, greetings from Bikaner, the desert city in the western area of India. I will be discussing about the malaria, which is one of the simplest disease to diagnose and the easiest disease to treat. But see, the morbidity and mortality. In 2021, it caused more than 627,000 deaths, and it happened in about 241 million people affected by malaria in last year. So, what is known in 20th century? We knew the clinical presentation, we knew the parasite. The description of severe malaria was given by WHO in 1990, and they have definitely defined it. Pathogenesis, we were knowing that sequestration is the important. Since the era of Marcia Pava and Biganami, they were the amongst first to describe it. The diagnosis, peripheral blood film, thick and thin smear. Treatment, only one treatment, that was IV quinine, in spite of the fact that it was very toxic. There was many mortality associated with quinine also, but then this was the only treatment. Vaccine, very little thing which is known about the vaccine at that time. Falciparum and vivax are the two important parasites which are present in India, and we were having some knowledge about knowledge. It was a monkey malaria, but then there were reports in the end of the last century that probably it can affect human being. Of course, female anopheles causes the bite of that causes malaria. One thing about the life cycle: mosquito bite, sporozoite enters, it enters the liver, asexual cycle in men, taken up by mosquito, sexual cycle in mosquito, and then again the cycle continues. One important thing is that the presence of hypnozoid sometimes causes persistence of malaria and relapse. So this occurs only in vivax. When patient comes, either it is uncomplicated, fever with chills and rigor on alternate day, you take the treatment and you become all right. But once we say it is severe malaria, the WHO has defined it a specific organ dysfunction, which we will be taking one by one, and when they are present, along with the presence of parasite in blood, we say it severe malaria. They can be because of sequestration, like organ involvement in cerebral malaria, renal failure, liver, lung, or it can be non-sequestration like severe anemia and thrombocytopenia. When it comes to define the cerebral malaria, it is unarousable coma, and in last century it has to be GCS less than 9 or 9, in which the bacterial meningitis and other locally prevalent encephalitis has been ruled out by specific examination. It presents as a diffuse encephalopathy. Clinical feature, coma was an important thing. Conversion is very, very common, more common in children. Neck stiffness is very common in Indian patients. We can have retinopathy positive in the form of papilledema and retinal hemorrhage. Patient may have psychiatric manifestation, and then there is brainstem signs like changes in pupil, gaze, respiratory pattern, posture, and cranial nerve involvement. These are some of the actual picture. Severe neck stiffness, or we can say neck rigidity. We have to do CSF to say that it is not meningitis. Conjugate deviation of eye, marked rigidity all over the body. Patient may have trismus. Sometimes we have to differentiate it from tetanus. Then patient can have stroke with the definite evidence of infarction. Basically it is uncommon, but then we have reported about 2 cases in different times in Vivax and falciparum. Occasional patient may have cerebral syndrome at the time of presentation with fever. Otherwise, patient may have cerebral malaria, becomes all right, and can have as a sequelae, and sometimes just like Guillain-Barré syndrome, post-infectious delayed cerebral ataxia. There are case reports of ADM, Guillain-Barré syndrome, cranial neuropathy, periodic paralysis, but then they are very, very rare. A word about neurological sequelae in survivors of cerebral malaria. Once the patient becomes all right and comes out of coma, patient may have psychosis, cerebral ataxia, rigidity, hemiplegia, neuropathy. The important thing to note is that all these, they are self-limiting. They may be transient, they may improve rapidly, and they may take a bit longer time, but almost all the things completely becomes all right at the end of 4 months. This is just about that. Out of 441 patients reported by us of cerebral malaria, the most important sequelae was psychosis, cerebral ataxia, and hemiplegia, and almost all the patients, they recovered completely by the end of 4 months. Just to share the important things, see this report. In 1996, there was absence of neuropsychological sequelae following cerebral malaria. We used to say that if the patient has recovered from cerebral malaria, he is as good as the normal person in the community, and we can just forget it about. But now, in the early part of this century, we had seen in last 15 years that many children have long-term neurological and cognitive deficit, and epilepsy is far more common in those patients who had cerebral malaria in their childhood. As on today, cerebral malaria is now considered as a leading cause of neurodisability in sub-Saharan Africa. I will be discussing it later on. Patient may have the other things associated with cerebral malaria are patient may have hypoglycemia, and at times it becomes very different, very difficult that the patient is having the symptoms and signs of cerebral malaria or hypoglycemia, and we have to do blood sugar in almost all the patients. There's very severe hemolysis, and you see the amount of red color urine which the patient is passing. Severe hemoglobinuria. This is very important component of these patients of cerebral malaria. All these 3 patients are comatose. Patient may have severe bleeding from all over the body. In last century, we used to think that it is because of disseminated intravascular coagulation, and we are treating these patients by heparin, but now it is absolutely clear that these are the patients of simple thrombocytopenia and bleeding from all over the body, and heparin has got no role as on today. Patient may have pulmonary edema, which is very common in children, and in second stage of labor, when there is sudden increase in the blood volume, and we have to be very, very careful in this situation. Patient may have renal failure. Biopsy shows the classical picture of mesangial proliferative glomerulonephritis, and we described for the first time that patient may have very severe jaundice. The bilirubin may go up to 40 mg% or more. We did histological, we definitely showed histological evidence of necrosis, and we gave the terminology of malarial hepatitis, which was not accepted for pretty long time, but then there were definite evidence, because not only we showed the evidence of hepatitis in biopsy, but we also reported hepatic encephalopathy, and this was our recommendation to the WHO to change the definition of severe malaria and add that patient also have hepatic encephalopathy at times when there is severe jaundice. There is evidence of retinopathy. Ophthalmological findings in the form of retinal hemorrhage and papilledema is very common. In fact, in African country, there is gross description of retinopathy positive cerebral malaria and retinopathy negative cerebral malaria. Those patients who are having retinopathy positive cerebral malaria are having worse prognosis than the other factor. We can have hemorrhage and papilledema. The poor prognostic indicator in cerebral malaria is whenever there is a combination 2 or 3, or there is a multi-organ dysfunction. When it comes to the picture of cerebral malaria in pregnancy, the pregnant lady is more prone to develop cerebral malaria, and cerebral malaria is more fatal in this situation. We can see from this chart, cerebral malaria is more common in pregnant ladies in comparison to non-pregnant ladies, and similarly, the mortality is also to the tune of 41%, which is otherwise in around 10 to 20%. This was again a very big series of pregnancy with cerebral malaria. A word about pathogenesis. We used to know that there is parasitized RBCs which go in the ultimate vascular channels, and they become they cause clumping over there, and there is endothelial activation in brain, and which because of hypoxia and focal ischemia in that region, which is caused by the sequestration of parasitized and non-parasitized RBC along with other factors. At this time, last century, we were not knowing the role of platelets in this, but we were not taking platelets in account. But then there was something which happened at that time in that region, which caused blood-brain barrier dysfunction, and there is a gross damage and intrusion of cell damage and the edema of the brain. To cause thrombosis in the terminal vascular channels and the classical ring hemorrhage, which we see in these patients in our autopsy and biopsy. These are the terminal vascular channels, which is completely blocked and clumped with parasitized RBC, and is a very important feature of cerebral malaria. It was known that there is a cascade which starts over there, TNF alpha, and ultimately it produces nitric oxide, and once the nitric oxide is produced, it causes severe neurotoxicity. Now this is the phenomenon. Nitric oxide is probably produced to protect the brain, but once it has started its action and there is continuation of this action, it causes severe neurotoxicity in times to come. Ultimately causing, in a normal, we know A is normal, D is mild edema, and in C, we have seen severe brain edema causing herniation and death. The diagnosis in that period was only thick and thin smear of showing peripheral blood smear positive of asexual parasite. Now this was the thing which was happening in the last century, and then what happened in the beginning of this century? There was a drastic change in our knowledge. Number one is we had antigen detection by rapid diagnostic test, and now the diagnosis could be done bedside, and this has proved very important, and we were able to diagnose the patient early and treat the patient early. And the other things which are revolutionary was the evidence that vivax malaria, so-called benign tertian malaria, can never be only benign. It can be also equally malignant as falciparum malaria. And we are fortunate that amongst the first important description of severe vivax malaria, it comes from Bikaner itself. We also knew that it causes severe neurocognitive deficit and behavioral alteration. And I discussed already the diagnosis. We had very new thing is antigen detection test, quick diagnosis, management, complete revolution. In last century, the quinine was the only treatment. There were many mortality which was also associated with quinine, but there was no alternative. With the beginning of this century, we had a very good drug by artesunate. It's very, very effective. It's very less toxic. And when there was a head-to-head comparison of their action, the study was stopped in between because there was a gross high mortality in quinine group. So we can imagine it's much wonder drug, and we can treat the patient thoroughly and completely. And now we also had vaccine in. Of course, it was just given, WHO has given permission only few months back, but then we definitely have a vaccine. So we can discuss one by one. We were the first to say that benign tertian malaria is not always benign. It was a question that it is really benign. We answered it that it is not benign, it can be equally malignant. This was the first description only from Vikander, in which we definitely showed that there is evidence of vivax malaria with severe malaria, and we described 11 patients in all age group, both the sexes, all the severe malaria, including cerebral malaria. There was complete recovery, there was death also, and there is also post-malaria neurological syndrome, which is usually seen along with falciparum malaria. I just want to say one thing. This paper was subjected to a minimum 6 to 7 referees, and I gave the heading severe vivax malaria. They ultimately asked me, we will not publish with this name because this is no entity like that, and they published it by the name of Plasmodium vivax malaria. And similarly, when I put the paper again in Lancet, again as a severe malaria with the status epilepticus, of course it was accepted, but then there was editorial comment that we will not publish it by the name of severe vivax malaria, and they changed the heading as an unexpected cause of fever and seizures. Again, this was the first report of BP vivax cerebral malaria with the status epilepticus. In times to come, we reported another 40 patients of severe vivax malaria, in which we also demonstrated with authentication that it can cause also death. At this time, the American Journal of Tropical Medicine and Hygiene, they accepted our wording to publish this paper with the name of severe Plasmodium vivax malaria. We did similar studies in children, and again we described in detail the clinical profile of 13 children of Plasmodium vivax cerebral malaria, which is still amongst one of the largest series, single report from a center. This time we compared the falciparum vivax malaria with vivax cerebral malaria and fatality, and we can see that there is not much difference. In vivax it is 6.15, and in falciparum it is 7.59. So not only we describe the details of P vivax cerebral malaria, we also put in world map that it can cause death, and later on after 2 years the WHO has also reported that it can cause death. Now this is the largest series in which we compared falciparum vivax and mixed infection cerebral malaria. It is the largest study on 24,000 patients of fever, in which there were more than 1,100 patients of severe malaria, majority of them with cerebral malaria. And again we compared that all the three can cause fatality. Of course, the fatality is more in mixed infection malaria. Again, the phenotype is also not very different. The patient can have very severe jaundice, patient can have multi-organ dysfunction, and we reported that presenting clinical features including multi-organ dysfunction and mortality pattern was almost similar in Plasmodium falciparum and Plasmodium vivax infection. We took another study with comparison from India in Bikaner and Brazil, and we noted that we are having almost severe infection, including cerebral malaria. However, fatality was more in Brazil in comparison to Bikaner. Then there was a question whether this vivax malaria and cerebral malaria can they cause the changes in pregnancy also. So this was the study which we took Bikaner along with eastern side as Papua New Guinea, the center, and on the western side Panama, Guatemala, and Colombia. And in these countries simultaneously we saw the effect of vivax malaria, cerebral malaria on pregnancy, and we found that it has got almost similar effect as we have seen and being reported with Plasmodium falciparum malaria. The same number, the patient have almost pregnancy loss and preterm life, intrauterine death, and all those things which are seen in falciparum malaria. A comparison of severe malaria, falciparum in falciparum and vivax, it is more common in children. Cerebral malaria is more common in children in comparison to the adult. Now, this was the first thing of this century, severe vivax malaria. And the second knowledge which I have gathered in this century was malaria-related neurocognitive deficit and behavioral alteration. We have already discussed neurological sequelae, which occurs just after the patient recovers from the coma, ataxia, motor deficit, hemiparesis, movement disorder, and all visual impairments, and they are self-limiting and they become all right. But the second and third, cognitive deficit and behavioral alteration, they are new. They were known to the world community only after 2002 or 3, when it was found that in the area where cerebral malaria was more common in Africa, the children were having lot of cognitive deficit and behavioral alteration. As on today, this is one of the most important morbidity in childhood. It is post cerebral malaria children. Attention deficit, learning difficulties, memory deficit, and cognitive ability deficit are far more common, and they can occur somewhere 6 months to 2 years after complete because after the child becomes completely alright from cerebral malaria. Similarly, there is behavioral alteration in the form of emotional reaction, sleep problems, disruptive behaviors, conduct disorders, and marked anxiety. The school performance and learning is also hindered. And the cause is, it is present more common in those who have prolonged coma, hypoglycemia, severe anemia, and multiple seizures. It causes brain injury. This is the hidden burden of malaria, and this is the hidden burden of malaria which is often unnoticed but may place the children at a definite disadvantage by causing cognitive impairment resulting in poor school performance and non-achievement of full potential of life. Third thing which had happened in this century is the treatment by artesunate. But simultaneously, we knew that in spite of very good specific anti-malarial drug, the mortality and neurological sequelae in cerebral malaria is very high because artemisinin controls only parasitic events, and once the cascade, inflammatory cascade, which is started, which we have to check, and it is unable to check it. So we require combination of adjunctive treatment which should improve survival rate, reduce cognitive deficit, and neurological disability or death. Depending on the pathogenesis, a number of agents were tried to put specific coverage on a specific event in pathology in the form of exchange blood transfusion, diperoxamine, heparin, inhibition of cytoadherence by PFPMP antagonist, levamisole, atorvastatin, acetylcysteine, endothelial fixing like nitric oxide and arginine, immunomodulation, very important, dexamethasone, pentoxifylline, immunoglobulin, anti-TNF alpha, monoclonal antibodies, and curcumin also healthy, neuroprotection by erythropoietin, but albumin, and we were hoping something very big from all these things. But see, a very important meta-analysis. The difference, there is no significant difference in safety and efficacy between the two groups, which those who received monotherapy and those who received artesunate and adjuvant therapy group. So we are still in the search of a very nice molecule which can cause, which can give a better result. Indian Institute of Science is working on curcumin. It has got additional advantage. Apart from antioxidant, anti-inflammatory, anti-angiogenic, and anti-spasmodic, it has got its own anti-malarial efficacy. So it has got a bright future, and probably in times to come, we may say that curcumin is having a very nice anti-malarial activity. Fourth thing which we knew was vaccine. Although it is a breakthrough, the first ever malaria vaccination only provide partial protection. A 4-dose regimen intramuscular vaccine showed protection from severe and several malaria only in 32.2% children aged between 5 to 7 months. It was not protecting the several malaria in the older than 17 months. So it is very good news that we had a vaccine, but then we have to go for a very nice vaccine. So we had a very nice time in this century, but we do not have exact knowledge of pathogenesis, including neuropathogenesis. We have to see, and in late, only about a year or two, we had known that there is some role of lymphocyte and spleen, and the people are in search of studies on lymphocyte and spleen. And management, we have to find a molecule which can be used as an adjuvant therapy, and we should have a better vaccine than what we have at present at our place. In pathogenesis, either there is important role of platelets, it was known, or there is resistance, or there is compromised host immune response, change in host-parasite interrelationship, or infection is caused by different variant. We are working in Bikaner, and we have studied the role of platelet, and we had found that not only the platelets, we do not know the cause and effect relationship, but then we definitely found in a study of these 1000 patients that there is marked thrombocytopenia, not only in falciparum, but in vivax, where the biomass is less, sequestration is less, there is marked decrease in platelet count. Probably platelet is also over there in sequestration and clumping. And in children, we observed that severe thrombocytopenia is very common in patient who is having severe malaria, and this was the recommendation that the severe thrombocytopenia should also be included as a part of severe malaria in WHO outline. I will be taking this opportunity that we are working on systems biology approach to see this interrelationship malaria in Bikaner also. So just to give a glimpse, but what we are doing the resistance study. We have seen the novel mutation in antibody drug resistance, and there is this docking of sulfadoxin molecule, and we have found that the strain in this area has got the docking is very loose in comparison to a normal docking. With the Indian Institute of Science in Bangalore, we are working on mass spectroscopy of these patients, and for the first time we have reported 29 new proteins in vivax in this region, and this is the interaction network in which we see that many of these newly reported proteins have got a marked interaction with already known proteins in parasite. So maybe we can have in later time something more important knowledge, and this is the systemic representation. Then we studied plasmodium vivax Vir proteins and T-cell immune response in pregnant ladies, and we had very important results, and we are working on that with this biopsy of placenta, and how we can do the changes in the immune response and changes in beer proteins. We are working on this scaffold protein soup A in Plasmodium vivax. We have designed in construction and validation of very good Plasmodium vivax microarray. We are doing in stress and skeletal protein as a possible marker in severe vivax malaria, so that we can identify by a blood test or urine test. And lately, we have done a data set of natural antisense transcript in P vivax clinical isolate. And this is the physical map of gene with antisense transcript of parasite chromosome, in which we have definitely found some initial good changes. We do not know exactly how the cause and effect relationship is there, and we are with the Indian Institute of with the IIT Mumbai, we are doing on rapid discrimination of malaria with spectroscopy. Elsewhere in the world, the people are working on neuroimaging just to see what is happening exactly at the time of cerebral malaria, because autopsy doesn't give a real picture. Neuroimaging can give a real picture, and depending on that, we can have a better molecule for treatment. Intravital microscopy is a way in which murine malaria, there is a cranial window through which they can see the live changes in the vascular channel. And once we know that once we have injected a drug, and we can see the changes in the vascular channel, and depending on that, we can say that what are the changes which are going on. Lately, in last 2 years, depending on the murine malaria, it was known. I will be taking 2 or 3 minutes. This is a very important breakthrough knowledge which we had known. In spleen, the malarial parasites, they are being taken by dendritic cell, and they somehow influence the changes in CD4 and CD8 lymphocyte. The CD4 cell help in production of this interferon gamma, and that the parasitoid RBC, it helps in being taken up by the endothelial cells. And once it is being taken up, this multi-specialty histocyte agents, chemokine receptors, they are activated, and CD8 cell, they are pushed towards endothelial cell, and they are making a clumping over there, and this CD8 cell becomes changed in cytolytic cell, and then they produce certain enzymes there, perforin, granulocyte, and they cause severe endothelial cell edema. Now, this is the cause of rupture. If this is really true, and if we know that this is the cause of rupture, probably agents which are acting against this CD8 cell will be very important agents for adjuvant therapy in the later on. And once there is a bridge gap, it enters inside and it leads to astroglial activation, neurocognitive changes, neurocognitive difficulty, behavioral changes, and cerebral malaria. From all these things, what we have known in this century, that probably the only thing which we know in pathophysiology and what we can conclude is most likely it is caused by a misguided host immune response provoked by parasite infection. If something which is protecting becomes detrimental. So, a word about rehabilitation. In African areas where the CM is more common, traditional and computer-assisted cognitive rehabilitation therapy, early childhood education, and parent-child intervention, it has proved very effective, and those patients who received it have less neurocognitive difficulty. Lastly, vaccine. The major breakthrough in elimination or eradication will depend on working on a better vaccine, and we all know production of a vaccine, it requires a strong political will. If there is strong political will, we have seen that it can be produced and it can work together. Probably that will be the final answer for eradication. Take home message: cerebral malaria is fatal but easily treatable. Vivax can cause cerebral malaria. Pathogenesis is still not very clear. Sequelae is self-limiting. We should not undertake all investigations for these patients. Neurocognitive deficit and relation to epilepsy requires more research in Indian setting. Artesunate, the treatment of noise, is a very wonder drug. There is a strong need for research on adjuvant therapy for neuroprotective agents. Thank you very much. I am highly thankful to my partners in BITS Pilani, IIT Indian Institute of Science Bangalore and IIT Mumbai, along with the people working with me here. Thank you very much for the patience hearing. Probably 5 minutes more I have taken. Thank you very much, sir.
Thank you, Dr. Kochar, for a wonderful talk. I think we now move on to the next talk, and I would ask Dr. Manish Modi to introduce Dr. Mishra.
Okay, sir. It's a pleasant privilege to introduce Professor Mishra. And again, he also doesn't need any introduction. He had been heading the Department of Neurology at SGPGI. And his major areas of interest are infections. And as we can see, more than 500 publications and almost all neuroinfectious diseases he has covered extensively. But I think the maximum publications in India on neurotuberculosis are none other than Dr. Mishra. So it won't take much time. We are already running late. So I'll invite Professor Mishra to share his experience on the recent advances in neurotuberculosis. Over to Dr. Mishra, please.
इससे जाना है किसे इसे ऑन कर दिया म्यूट पे कहाँ करें okay good evening ladies and gentlemen. I thank the organizers for giving me the opportunity to present some work on tuberculosis. Before I start, I must highlight that there is no neurology without good medicine. So I think interaction between physicians and neurologists is extremely important, and it helps both ways. So I compliment this initiative. And what I will be talking is drug-induced hepatitis and tuberculous meningitis and its implications. This is the last part of work which I did in last 3-4 years. So I thought I have not presented it anywhere. So I thought it'd be a good idea to present here. I start with a 30-year-old man who presented with fever, headache, vomiting for 4 months. CSF was adhesive, consistent with tuberculous meningitis. On day 15, he had hydrocephalus, seen in the first panel. He was shunted, a VP shunt was done, and he improved. On day 30, he had paradoxical worsening, exudates and granulomas occurred, seen in the second panel. And then he also had hyponatremia and cerebral salt wasting, which gradually resolved. On day 45, he had worsening and he had mechanical ventilation for 2 days, and then he improved. And then he developed drug-induced hepatitis. His SGPT was 118 and serum bilirubin elevated. So with this, then we stopped at anti-tubercular treatment and went off to treat in sequential and anti-tubercular drugs, which I will discuss later on. This slide shows that patients with TB meningitis have multiple problems, like they may have hyponatremia, and they may have infarcts and paradoxical worsening and many other complications. And these complications overlap. And more the complications, probably worse the prognosis. Drug-induced hepatitis is also one of these complications. Drug-induced hepatitis in TB accounts for about 2% of jaundice in the hospital, according to one study. 7% of reported drug adverse events. 30% of fulminant liver failure. This was by Lemmy et al. 2003. In some countries, it has replaced viral hepatitis as a cause of jaundice. And its mechanism is diverse, maybe direct toxicity, maybe idiosyncratic reaction, or maybe genetic susceptibility in various combination or in isolation. In Indian subcontinent, drug-induced hepatitis is very common. It has been reported in various studies, 8% to 43%. And in that case, you stop all hepatotoxic drugs and start sequentially, and you are able to restore the majority of patients. In the randomized controlled trial by Dr. Thwaites and his group from Vietnam, they showed the benefit of dexamethasone, mortality benefits of dexamethasone. And this, when you see the data closely, you find that the decreased mortality could be because of the lower incidence of drug-induced hepatitis, and therefore the drug interruption caused by that. We seldom do liver biopsies in the patient with drug-induced hepatitis, but this is liver failure. This patient from literature required liver transplantation. And drug-induced hepatitis in various books and journals, you see large amount of papers discussing various aspects. Now, when we talk about toxicity, you need to study the association. And these are Bradford Hill's criteria to establish an association, causal relationship. The strength of association here is not very strong. Hepatitis is found in 3 to 40% cases. Consistency, not all patients develop it when you give anti-tubercular treatment. Specificity is low. Temporality, it occurs from days to months. It may take more than a month or 2 months. Biological dose-response relationship is not proven. Coherence, histopathological evidence lacking, experimental evidence questionable. So there is not enough data to say that drug-induced hepatitis is a toxic reaction. I mean, this was a question in our mind. This complication is commoner in India than in the West. In India, it is seen in 8 to 39%, whereas in Western literature, 2 to 3%. It is acute or subacute liver failure, and it may be fatal in 10% cases. The predisposing causes may be elderly, 50 years of age, females, hepatitis carriers, alcohol consumption, malnutrition, establishment status, and severity of tuberculosis infection or genetic susceptibility. These are some of the etiologies which have been suggested. In any toxic condition, when we challenge, we should get the toxicity again. But here we are able to restore INH in 96%, rifampicin in 88%, and pyrazinamide also in a large number of cases. If we don't stop the treatment within 6, then it leads to worsening of the liver functions, and therefore it's very important. And in case of patients with liver disease, you hold on INH, pyrazinamide, and rifampicin. And we start the treatment with the ethambutol or quinolone, and then go on to introduce isoniazid, rifampicin, and pyrazinamide sequentially. This is result of a meta-analysis in which, INH and anti-tubercular treatment without rifampicin, and INH and rifampicin, the number of studies is said in the bracket here, and number of patients are mentioned in the second column, and the frequency of hepatitis is mentioned here. So INH and rifampicin produce the maximum hepatitis, followed by INH and other anti-tubercular drugs. In an earlier study, which we studied 150 patients. This was a study on rifampicin versus levoflox, and we found that drug-induced hepatitis occurred in 43% after a median of 13 days. What was the nature? SGPT was elevated in 17, bilirubin in 3, and bilirubin and SGPT in 21 cases. The predictors of drug-induced hepatitis were Scheizer's low albumin, CSF protein, and raised intracranial pressure. And there was also higher mortality, but not significant, but the outcome was worse in the patient with drug-induced hepatitis. This study was done long time back and forgotten. Interesting to note, the drug-induced hepatitis is more common in TBM, tuberculous meningitis, than non-TBM cases. In pulmonary tuberculosis, 2 to 3% cases. Tuberculous meningitis, 40% cases. So it's very, very interesting. And it occurred in another study, it occurred in 43% of our cases. And this time, when we repeated this study with the, which is mentioned in here, then we found that the drug-induced hepatitis is related to GCS, Glasgow Coma Scale, stage of meningitis, SARS parameters, systemic inflammatory response syndrome, CRP, ESR. We also studied cortisol, but it was done in a small number of patients, did not achieve statistical significance. And it was associated with paradoxical worsening in half the cases. So half the cases had paradoxical worsening. And multivariate analysis revealed that stage of meningitis was independent predictor. So severe meningitis, more drug-induced hepatitis. And this time we had a significantly association with mortality. The same data presented here, the Glasgow Coma Scale and stage were the significant predictors of multivariate analysis. And other parameters, ESR, leukocyte count, CRP, and SARS were also significant. And the lower column shows the relationship between drug-induced hepatitis and paradoxical worsening, almost similar. Then we thought that why not look at the oxidative stress markers, and my PhD student looked at these markers. And what we did, where oxidants and antioxidants were evaluated in the blood, and we found that on admission in the first column and at the time of drug-induced hepatitis in the second column. In the bars, you see the lighter one on the initial, and the darker green is at the time of DIH. And you see that there is malonaldehyde, protein carbonyl, SOD, catalase, glutathione, and then ER stress markers. They are all significantly altered at the time of so there was oxidative stress during the drug-induced hepatitis. We looked at these data at baseline, during DIH, and after correction. And again, you can see there was significant relation of oxidative stress during DIH, and it improved as the DIH subsided. This slide shows the dose response relationship. The mild DIH and severe DIH, we had categorized them, and then we looked at the oxidative stress markers, and they are shown in these, the milder one in the light green and the severe one in the dark green. And you can see there is significant relationship, significant oxidative stress during severe drug-induced hepatitis. And we also compared the data between controls and the patients with DIH, and you can see that oxidative stress was there compared to controls. And these are the Kaplan-Meier curve showing that the better survival of patients without DIH compared to those who had drug-induced hepatitis. So drug-induced hepatitis in this study occurred in 39% and was related to oxidative stress, MDA, GSH, and total antioxidant capacity, and ER stress marker, CHOP, GRP1780F4. Now coming, there's always a strive, we are striving to have more intensive treatment to control tuberculous meningitis and reduce mortality. So intensive anti-tubercular treatment has not reduced mortality of TBM. And the newer drugs which have been added, lately have not influenced the mortality so far. So intensive treatment has been associated with high incidence of side effects, including drug-induced hepatitis, and leads to interruption in treatment. Then this summary of high-dose rifampicin 15 milligram per kilogram with levofloxacin 20 milligram per kilogram, there was high incidence of adverse reactions and the treatment interruption without any mortality benefit. And the adverse events were visual impairment, drug allergy, jaundice, and grade 3 and 4 hyperbilirubinemia. One study by Tahagolu in 2001, they showed reduced occurrence of drug-induced hepatitis compared to the standard treatment. If you give the antitubercular treatment sequentially and not simultaneously, they showed lower incidence of drug-induced hepatitis. Now, coming to other infections of the initiation of antibiotics is associated with transient worsening. In spirochetal, bacterial, fungal, and protozoal infections is well known. In louse-borne relapsing fever, tetracycline resulted in life-threatening Jerick-Hersheimer reaction in 47% patients. Penicillin, which clears the spirochetes more slowly, produced fewer reactions and less severe Jerick-Hersheimer reaction. So, low-dose penicillin of 1 lakh unit resulted in Jerick-Hersheimer reaction in 5%, and high dose resulted in Jerick-Hersheimer reaction in 31%. So heavier dosage was associated with more worsening. And so it was recommended in these disorders to use low-dose penicillin. And we all have seen lepra reactions and iris when we give treatment, and we also are aware of paradoxical response. When we have a patient with tuberculous meningitis and he develops jaundice, then what we do, we stop all the treatment and then give ethambutol and then go on to administer the drugs sequentially one after the another, or wait for some time when the liver function is normalized, and then we administer the drugs sequentially, and we are able to restore the treatment. And this happened in our experience in 2 studies in about 40% cases. So this gives an opportunity that why not look in a randomized manner, give them sequential treatment and give them standard treatment and see what is the frequency of drug-induced hepatitis and the outcome. So this was the genesis of our study, to compare the safety and efficacy of sequential antitubercular treatment regimen with the standard regimen in TB meningitis. This was a single center open label parallel group randomized trial during 17 and 19 at SGPGI. We used treatment naive patients, and we gave 4 drug antitubercular treatment, RHZD, or we gave sequential treatment, which I will detail later on. Primary endpoint was drug-induced hepatitis, and secondary endpoint was in-hospital death and disability at 3 and 6 months using modified ranking score. The exclusion criteria were children, hepatitis, ultrasound abnormality, hepatotoxic drug intake like methotrexate, phenytoin, valproate, etc., MDR, lack of consent, chronic renal failure, hepatic failure, heart failure, any malignancy or contraindication to antitubercular drugs. Patients received ethambutol 15 milligram, 800 milligram usually, and on day 1, and we gave prednisone 30 milligram and aspirin 150 milligram. Sequential treatment was first isoniazid, rifampicin, and paracetamide in this manner. The diagnosis of drug-induced hepatitis criteria are mentioned here. They are very detailed, but what I mean to say that if there were 3 times elevation of ALT in symptomatic or 5 times in asymptomatic, then it was diagnosed as drug-induced, and on withdrawal, the patient should improve and he should have no other cause to account for hepatitis. This is our flow chart, and we screened 97 patients, but actually randomized 40 patients in each arm, and finally 39 and 38 patients were analyzed. These are the comparison of standard and the sequential group, 40 patients in each arm, and you can see that the demographic features, duration of illness, stage of disease, etc., they were all similar. Seizures, extra serious tuberculosis, focal weakness, BP shunt, all these parameters are also not different. The laboratory parameters, bilirubin, liver functions, hemoglobin, CSF protein cell, etc., were also not significantly different. MRI findings of tuberculoma, hydrocephalus, basal axillary infarction were also similar. Now coming to the endpoint, the primary endpoint, number of drug-induced hepatitis was significantly better in the sequential arm, 8 versus 17, 20% versus 40%. Hospital mortality was also significantly lower, 2.5 versus 42.5. Then a time to onset of drug-induced hepatitis was also significantly better, 7 versus 21. Hospital stay were significantly lower in the sequential arm, and 6-month outcome was also better. These are the Kaplan-Meier, and it shows that the patients with the sequential arm were having much better outcome. So sequential antitubercular treatment was associated with lower frequency of drug-induced hepatitis. It had lower hospital mortality and better 6-month outcome. Drug-induced hepatitis seems to be related to the severity of meningitis. It is related to oxidative NER stress, and sequential administration seems to be possible and associated with better outcome and reducing the frequency of drug-induced hepatitis, but it needs to be confirmed in larger study. I thought that, we have been, right from residency, we have been noting this phenomena of hepatitis and then going on to sequential treatment. So this was the result of this study, and we found it very encouraging results. So I thought it is, I was excited to share it with you. And in this work, I must acknowledge the help and support Dr. Jayanti Kalita, my first student and now my colleague, is the professor at SGPGI. Sriram was associated with looking at the drug-induced hepatitis, the first paper, which was published in an online journal, but this is what it is. And Mrityunjay Kumar, and down below, is at Rishikesh AIIMS. He is one of my very, very nice residents. And Abhilasha does the experimental and the laboratory work. She is going to submit her PhD next week. So, and Dr. Mishra on the other side helps us with this. Thank you very much for your attention.
Thank you, sir.
Thank you.
Dr. Mishram, sir, you carry on.
Yeah, I think we are just in time and finish. There are hardly any questions. There are 2 questions. I think they are already answered during the talk. About
let Rahul Kulkarni take those questions, please.
Yeah, Rahul, over to Rahul.
Yes, so maybe there are a few questions, not many questions. So one question is for Dr. Pujari, whether COVID causes vasculitis and what's the pathophysiology behind the COVID-related stroke. So Shripad, if you can answer this.
Yes, yes, very important point that was raised is, as I have already elaborated in my lecture, that rather than calling it just vasculitis, we should broadly term it as vasculopathy, and it is a combination of many factors. We all know any infection by itself triggers or is causative for stroke, more so particularly in COVID, because we all know it causes endothelial inflammation and more specific affinity towards ACE2 receptors, and also the cytokine release that leads to even further endothelial damage and leading to endothelitis, and that itself is a cause of vasculitis. Plus, in addition, it creates a procoagulable state leading to in situ thrombi that adds to the risk of stroke, and uncommonly even at the cardiac valvular level, and rarely severe lung infections can lead to atrial arrhythmias and predispose to stroke. So rather than just focusing vasculitis, which itself has its own pathogenesis, it leads to broad vasculopathy.
Okay. Dr. Garg, there's a question for you. What is the role of serum anti-measles antibodies in patients suffering from SSP?
The serum anti-measles antibody titers are usually raised, but they're non-specific. If you want to specifically test for virus in the brain, then the CSF anti-major antibody titer is much more specific. So the anti-major antibody titer in serum is non-specific, and while in CSF it is specific.
Okay, thank you. So these are the questions. Any other questions? Anyone wants to ask any question? We had a wonderful discussion, and all four speakers really gave a good insight about important neurological topics which are particularly important for physicians. So back to Manish and Meshram sir.
Rahul, there is a question for Dr. Mishra. And the question is in the, not the question answer, but in the chat box.
Okay.
So the question is that most of the hepatitis is drug-induced hepatitis in TBM cases? This is what Dr. Rajesh Verma has asked.
Okay. No, we should not say that. You know, when we diagnose drug-induced hepatitis, we have to exclude. It's a diagnosis or exclusion. So we have to, as I mentioned, exclusion criteria. You have to rule out all viral hepatitis, all drug-induced hepatitis, all other things. Then only you can diagnose drug-induced. There should be no other cause explainable. Then only you can say that. And you know, then the criteria. Then when we draw the drug, the ALT levels and liver function should improve by 50%. So that is how it is diagnosed. Not all. We should never say that all hepatitis in TBM is because of drug-induced. No.
Okay. So there's another question, Rahul, if you can read it from the chat box. Partha has asked.
Yeah, give me a moment. So what is the experience amongst pulmonary TB patients? Is there any pharmacological explanation for the drug-induced hepatitis? Is the sequential introduction is better than the standard simultaneous therapy? And is there any subgroup?
Very good question. I think it's a very good question. Thank you for this question. You know, this is what I have been trying to say, that the drug-induced hepatitis, if it was a pure toxicity, then you challenge and you will develop hepatitis again. And what we are seeing here, that the drug-induced hepatitis occurs, you withdraw the drug, manage him, and after some time, as the crisis subsides, you are able to reintroduce. So it is against the the evidence of toxicity. What I think that it is a stress response. What we have done, therefore, all the oxidative stress, the ER stress parameters have been evaluated. I want this to be explored further, at least in a significant way, that you are able to introduce the same drug. And in pulmonary tuberculosis, if there is no such severe stress, as you know, the stress in pulmonary tuberculosis is much lower, unless there is other conditions, all that. So we have done that data, and we have looked at the catecholamine levels, etc., which I did not want to present here. So pulmonary tuberculosis, Pott's spine, we have looked at these data. They do not have such high incidence of hepatitis. It was 3% in pulmonary tuberculosis, 8% in Pott's spine, and 40% in tuberculous meningitis. So it is related to the systemic stress response. Once the stress is controlled, then the hepatitis disappears. And you can you challenge it again, patient will tolerate all the drugs. Therefore, if gradually we have to persuade that maybe we will call it a stress-related hepatitis or TBM rather than a drug toxin, or maybe both are operating. Maybe there is an innate toxicity of certain drugs. I'm not contesting that, but I sincerely feel that the systemic stress is contributing to the hepatitis, which improves as the stress declines.
Okay, and there was one more question, sir. Whether is there any guideline about reintroduction of the drugs? How do we reintroduce?
Oh yes, drugs? Oh sure. There is a guideline. I did not go into that detail. But those guidelines are guidelines. We generally what we do, we start with the ethambutol and levofloxacin, and then isoniazid, 100 milligram, 200 milligram, 300 milligram at the 2 days interval. And then you go on to rifampicin, 100 milligram, 200 milligram, and 300 and 450 milligram. And then pyrazinamide in the end. So, these are given sequentially one by one. And these guidelines are by the British Thoracic Society, so we can follow them. They are available.
Yes. There's one more question for Dr. Garg. which says that in SSP, what determines the distribution of the MRI changes? Because you showed that lady first who had that RCVS-like changes, or the PRESS-like changes, who had later turned to be
that lady has some unusual changes.
Yes.
But
So
generally it is the periventricular hyperintensities, and this hyperintensity is more severely affecting the paroxysmal condition, of course, but it is periventricular.
And one more question, it says that whether you should do anti-mutant antibodies routinely in all acute encephalitic cases in India with myoclonus.
Yes, of course, I will recommend that. Because if you do that, more and more SSP cases you will detect. And I'm warning that because of this lack of measles vaccination, and large number of SSP cases we are going to see in years to come.
Rahul, there's a question for Dr. Kochar, if you see in the chat, about the genomics, genetics of Bikaner cohort.
Yes. So it says that the genetics of parasite. Have you done any genetics in Bikaner cohort, local genetics in your area, sir? Whereby, you know, the work that you showed, is there any role of genetics in a particular susceptibility to Vivax in that area?
All these reports were from Bikaner samples itself. Yes. They were done in BITS Pilani. We are having close collaboration of IIT Mumbai, Indian Institute of Science, Bangalore, and BITS Pilani. And all these things, the genetic part which I had shown is done by us. That was not from the papers. That was done by us. Fine. These are all on the Bikaner isolate field samples of Vivax.
Okay. Thank you. So one more question, last question, I think, to Dr. Garg. Is there any possibility of spontaneous remission that will happen in SSP?
Hypothetical.
Okay. Okay. Yeah, thank you. I think we had a wonderful discussion. So back to the chairpersons, Manish and Meshram sir.
Yeah, thank you. I think we had an excellent session, and talks were presented by the people who are expert in their field, and they have done a lot of research in the area that they presented. If you have any further questions, I think you should you can visit the IN website, and your questions will be answered. Over to Dr. Maheshwari.
Thank you, sir. It's a very good discussion, and all the four speakers are there, renowned persons and representative that this thing from the India, and their work is so much, because last 30 years I am listening all the things. Garg, Dr. Kochar, Dr. UK Mishra, Dr. Pujari. Recently his work was excellent in the COVID time. So sir, that's a nice presentation for the physician's point of view as an expert, when to take the opinion of the neurologist or when the certain guidelines is there. So I think it's a very good purpose of the doing IAN, API, CME, and of course in the next year we request that to the president-elect as well as to the president that this series to continue. Thank you, sir. Over to Dr. Nirmal Surya, sir.
Thank you, everybody. It's a wonderful session today we had, and I'm glad that in last session one of the physician has suggested that it should be case-based, and I'm glad that today many of the presentation were case-based to, you know, and I will keep that in mind even in the future presentation that the discussion is case-based. You can send your feedback. Those who have missed out, they can watch the program on the YouTube channel of Indian Academy of Neurology. I would suggest everybody to please subscribe the Indian Academy of Neurology YouTube, so that you can not only go through the session of Freedom Series, but many other sessions like Legend, Talk Show by the Legend, Dimag Pe Charcha, they all will be, and other fundamental course, they all are available on the YouTube. So you should become the member of that, subscribe that, and follow Indian Academy of Neurology on the Facebook, YouTube, Twitter, so that you can get more and more infection. With that note, I thank you very much. And next session will come next month on neuromuscular disorder, and we'll send you the program. Thank you. Good night.
Thank you, sir.
Thank you. Thank you, everyone.
Thank you, sir.
Thank you.
Thank you very much, everybody.